All right, let's get started then. So here's our objectives. We'll come back to these. So the important thing we want to talk about today is just healthcare is performed in a team environment, even when we are working as outpatient PTs when there's not a lot of other people around. Um, it's still a team environment. So the team, I think we talked, if you guys can remember way back before spring break, we saw that picture of all of the healthcare workers around the circle and the patients in the center, right? And so that's how what we mean by healthcare is executed in team. It's not just PTs and PTAs. Obviously, in hospitals, there's a million members of the team. How about in the nursing home? How many members of the team are there? How many different jobs are there? Different titles? A million, right? And you don't work at the biggest nursing, but like you can think of even hospitals, like even more and more. How about your nursing home? How many different? A ton, right? Um, but even if we're at outpatient, like we're at that high bar, we got our PTs and PTAs there. Do you guys have OTs there at all or no? I don't know if any high bars have OTs. Um, but some places do, some outpatients do. But guess what? We still need to talk to the patient, number one, as another member of the team. Uh, their primary care doc, maybe their orthopedic surgeon, maybe their neurologist, maybe their cardiologist. So family members. So there's a lot of other members of the team other than just who's in our rehab world. But by definition, you as a PTA, you have at least one other member of the healthcare team. That's the PT, right? So when we work with other members of healthcare, we need to know what they do so we can understand. So one, we can talk intelligently to them, but also give them valuable information, receive their valuable information, ask questions, give referrals. So, hey, I saw this problem with the patient. I don't know if anybody else picked up on it. Let's find that member of the healthcare team to help us out with this. But also to maximize visits and improve outcomes. I love when I get to co-treat with my OTs and even speech, where we get to all go to the treat the patient at the same time to really maximize each other. What are you seeing here? How come we're doing this? Um, how can we make this part better? And actually, I like doing it a lot with OTs, but speech is my favorite to do it because I don't know very much about speech. Um, so when I have a patient who has either some sort of cognition or some sort of speaking problem, um, I do the speech home exercise program during my PT stuff. So if I'm working on standing balance and the speech therapist is working on pronunciation of words, a lot of times they use flashcards to that kind of stuff. Where are the flashcards the speech therapist left you? Perfect. We're going to do squats. And every time you come up, I'm going to show you a different flashcard. You get to say giraffe, star, squat, whatever, number three, whatever it might be. Well, that wouldn't happen if I didn't talk to the speech therapist and say, what are you seeing? What are you working on? How can I enhance your stuff? And she can also, my speech therapist, what she does, she says, Josh, this person is doing pretty good for speech. What are you working on PT wise that I can help with? I say, actually, we're just working on standing tolerance. So if you could, as you're doing your speech, do it standing instead of just sitting in the kitchen chair. That would help me out a lot. Great. Like that's how we maximize each other's visits and improve our outcomes. Because now if that's how I and every other person is treating, this person is going to get a lot better, a lot faster. So So our main healthcare settings, hospitals, skilled nursing facilities, home care, outpatient, and schools. When we looked at the demographics, this is, gosh, is it week 3 we looked at demographics of PT and PTA employment settings? It feels like forever ago and also yesterday at the same time. Did that feel like, I don't know. So what was the number one work environment for PTAs? You got it? Outpatient's number one for both PTs and PTAs. Skilled nursing facility wasn't on the list of the data that we saw, but I know it's up there. Hospitals after would be number two. Skilled nursing facilities somewhere either second or third, depending on the research that you look at. So, and then schools, we can talk a little bit about schools. What do you think is unique about schools, the school environment? Not like me here, although there's some unique things that happen in academia, but schools as far as like the special needs kids that need services, PT, speech, OTs all work in the schools with all of those other, wherever you guys went to high school, that's where they're working. So what do you think is unique about that? Few things that are unique. What do you think? Kids, so pediatrics, although we could work in pediatrics with all of these, right? We have pediatric hospitals, some pediatric skilled nursing facilities. I have seen plenty of kids in home care and definitely an outpatient too. But yeah, it's always kids in schools. Yep. Although up to the age of on the 22nd birthday, if you have perfect diagnoses, so it's a little bit beyond what we would consider as 18. So, but yeah, kids. Yep. Anything else unique that you can think of? I think the unique thing is there's members of the team that aren't healthcare personnel. You have teachers, principals, teachers' aides, the dietary staff isn't, they're making the lunches at the schools, but they think they're at the school, and it's a little bit different than the dietary at the nursing home or the hospital where you kind of know what you're getting into. So yeah, we have non-healthcare workers in the schools, and now some of our job is to translate medical knowledge for these non-medical workers. And they're going to do the same thing for us for education. Hey, for their education, here's what I think and want to see. So that's a unique environment. So main goal for each setting, hospitals, get out. Get out is the main. You probably hate me saying that, but get the patient medically stable. That's the number one. And then get the patient out. It doesn't have to be home. Obviously, everybody would like to get to home, but this patient if they are now medically stable, they do not need to be home. We can send them to a rehab. We can send them to a nursing home. We can send them somewhere else. But yeah, hospitals want to get you out as fast as possible. Within 3 days is what most places their internal goals are. Obviously, if you're not medically stable, they're not going to say, "Well, it's day 2. What are we going to do tomorrow?" You're going to have to get that medically stable first. Skilled nursing facility now is improved functioning to get the patient home. Or if they're unable to return home, maybe they have to transition to being a resident. Now they have to live there. In home care, our two goals are: one, make sure you're safe functioning within your home. It's so tough, these skilled nursing facilities and even hospitals when they discharge the home. We're relying on patient report and we're relying on family report for saying, oh, we have 1 step to get into the house. Well, no, it's actually 3 steps and you don't have a handrail. That's not once. They're like, so sometimes I've been in houses where, oh no, in the first floor, it's all 1 floor. Bedroom, well, but except I've been in some houses where there's actually a step between the living room and the kitchen, and then the kitchen to the bedroom. There's 1 step on each. So yeah, is it all one? Do you have stairs in your home? Yes. Is it a flight of stairs? No. So that's where it gets a little weird for me going into somebody's home, and sometimes I say, how the heck did you end up back here? You should have never been here in the first place. But my number 1 goal is safe functioning within your home. Let's get you, how is that happening? And then some of our patients, how do we transition to outpatient when you're able to? not all of my patients will transition to outpatient, either because their problems resolved and they don't need it, or because they'll never do that safely in and out of the house that frequently. And then outpatient, man, outpatient, we get to have the most amount of fun, improve that quality of life. I hope that all throughout we're improving quality of life or enhancing movement. I'm sorry, improving movement to enhance the human experience. We can enhance the human experience by getting out of the hospital. Like that's the number. Like nobody wants to be in the hospital. I haven't met. Well, I met one person. That was a different story. But yeah, I mean, all along we're improving the quality of life, but in outpatient, we finally get to say, what are your goals? Home care, I come in and say, I get to tell you what my goals are. Safe functioning in the house. I watched you walk around and it looks like you're going to fall next time you try to go to the bathroom. So let's make that a lot safer. I know you want to play with your grandkids and go to their soccer games, but that's way down the list because right now you're gonna fall down if you leave the windows open and there's a stiff breeze. So let's not worry about that. But in outpatient, you get to work on those things. You get to start thinking about what is that quality of life? What's really important to you? Do you want to return to bingo? Do you want to return to playing sports? What is it that you're trying to get out of life? And that's, I'm sure, rookie, that's stuff, that's conversations you have all day long, right? What are you trying to get back to? Uh, some conversation, I bet you have some people that you say, we're just trying not to fall down again, Mrs. Jones, right? You got a couple of those people.
Yeah, we try hunting for something new, that's kind of like a lighthouse.
Yeah, yeah.
And, if they want to do something, trying to buck them, like, all right, we'll get you to that point.
Yeah.
Typically.
So anyway, I mean, what's quality of life mean to you? For most of us, it's work and leisure. Those are the big things. Sometimes it's your role is in your family member. Like there's something that it's a conversation. It's so funny how the human condition, like we will complain about doing the dishes all the time until we can't do the dishes. And then we feel like we're a burden on whoever has to do the dishes. Like, gosh, like I usually clean the dishes in my house, clean up after dinner. I do the dishes. Kids run around for an extra half an hour, and then I give the kids the tub at the end of the night and get them ready for bed. Right. So that's my task. If I couldn't do that, and now my wife has to pick up that slack, everybody will adjust and be fine, but I will feel awful. When my son, he's 8, so he stopped doing this except when he's sick. But when he's sick, he still lets me carry him to bed, so that's nice. My daughter, I get to carry her to bed. She's 3 now, so 3.5. Don't forget the half, or else she'll yell at you. So right now she's letting me carry her to bed every single day. If I had some sort of shoulder problem and I couldn't carry my son when he's sick and my daughter just every day, that would be a huge problem for me, right? So I know we say here quality of life, work, and leisure, but it's also your family responsibilities and anything else that you value. What are your personal values? Schools, the big goal is to maximize education. So in the school setting, if the child has stairs at home, but there's no stairs at school, we don't work on stairs. And no other setting would we say we're not going to work on stairs. But in schools, if that's not going to maximize the child's education, if that's not a requirement in that child's education, we don't have to do it. Yeah. So that's a great question. So if we had an elevator, could we, right? So does that mean we can't do stair training in the school environment? And the answer is it depends on the child. If they have the physical ability. So one of the goals of school is maximize education, but that's also with their peers. So if everyone else in the school gets to leave the classroom at the ring bell the bell rings, and then they walk down the hall to their next classroom, and maybe a flight of stairs is involved. If every single other child in that school is doing that, why can't this child? Is that because they physically cannot and they use a wheelchair for locomotion? Okay, then they're never going to do it. But if it's just not efficient, now that's something we get to work on. And I think the best example is probably in that week 1 video of that kid with the crutches. Yeah, and we're going to work on so you're walking in hallways for school. It would be easy to throw that kid in a wheelchair and say, it's just faster, safer. He'll leave class 5 minutes early every single day, so he's in the hallway with nobody else. All right, but that's not with his peers. That's robbing him of that piece of the education. So yeah, it's very case by case basis. Now, another example of that is, all right, well, the bus has stairs. So if this kid is using the bus for transportation to and from the school, now stairs are part of the care plan in the home care. I'm sorry, in the school setting. But if they're using a wheelchair for locomotion, that's off the table. So, so in the hospital, the team in the hospitals biggest healthcare, most variety in as far as the number of members of the team and the variety of jobs in one location. There's physicians. There's lots of different types of physicians. Physician's jobs: order tests, examines, evaluates, sets up the plan for the patient, performs procedures, on and on and on. Does a bunch of paperwork too. That's probably their main job. We have our rehab team, which includes physical therapy, which we've covered a lot. Occupational therapy we'll cover a little bit more. Speech therapy we've talked about a little bit. Recreation therapists, man. All right, so PT in general, we talk about we're gross motor. How do you stand up? How do you walk? Right, big motions. OT typically will do fine motor. How do you dress? How do you comb your hair? How do you cook? How do you chop vegetables for dinner? That's all more fine motor tasks. And then coordination too. So basically PT will help you get in and out of the shower. OT is going to help you turn on the water, grab the shampoo, put it in, like, shut the cap of the shampoo, all of those other steps. Now, I put lower extremity versus upper extremity. A lot of times in hospitals, skilled nursing facilities, home care, the general rule is PT handles lower extremity, OT handles upper extremity. The reason is because we both can't bill insurance for working on the same problem. So if I'm working on the guy's knee pain, OT can't come in and work on the knee pain because insurance is already paying somebody to do that. Right? That's called duplicative services. Now, if I've got a patient who has advanced knee pain and the rest of it, they just have a bunch of OT needs, I'm going to have my OT do a great job with it because I feel my OTs are great and can do everything. If I've got a patient who doesn't need a lot of fine motor activity but has shoulder pain, I'm going to tackle it because I do a great job with that. So in the hospitals, the problem with insurance is they start playing funny games, and then our bigger healthcare teams start playing funny games too. And the easy way to do it is just to say PT does lower, OT does upper, and then we're never in trouble, which eliminates some critical thinking. And that anytime you eliminate critical thinking, mistakes can be made. But anyway, speech, we'll obviously do speech therapy. How do we formulate those words? How do we project our voices? Also swallowing, and also speech does cognition as well, a lot of cognition. My speech therapist, a lot of times, you guys ever, maybe you've done it or you've seen someone do it. You ever see like at a bookstore, you ever see like third grade math problems? problems. It's just a workbook of math problems. Or this is going back in the early 90s, so maybe I'm dating myself with this. You guys ever see the like brain games? They're like almost like flashcards all in one stack. Like it's a lot like that type of stuff, right? So that's what that cognition is. So some basic math. And if you think of it, even if you don't, even if you're not an accountant, everybody needs basic math. You got to count how many potatoes are in your recipe. You got to count, how many bananas you're going to eat this week. You got to pay your bills. So you need some basic math skills. So all of that stuff is important. Now, I'm going to pause for a second on recreational therapists. That's the best. These recreational therapists walk around, usually just bigger hospitals. Not every hospital has a recreational therapist. I don't think most skilled nursing facilities have it. Do you know of any? They might exist, but yeah. Anyway, they probably don't. Some of the bigger ones. So these recreational therapists walk around with a cart of games. Sometimes they're video, so it's not activities. So it is a rehab. So they're doing it for a purpose. It's not just, hey, you're stuck in this building for 6 weeks. Let's make sure you don't get bored and start throwing punches. Like it is a little different. It is a insurance reimbursed thing. So what these people do is they get to have all of these games, video games, card games, board games, and they get to play games all day long. And what they're doing is what do you have to? I played Uno with my son was homesick today. So I played Uno with my son. What do you have to do for Uno? You have to hold cards, shuffle maybe. You have to also think of a strategy. You have to recognize a pattern. Here's a number, here's a color, so there's a lot of cognitive work that goes into playing games. It's just instead of here's my second grade, math book that we're going to do today, we're going to play a game and we're going to count and do all of those things with that. So yeah, I looked into it when I really I was having a bad career month and I started looking into it. I think that I found one program in Connecticut that is it, but at the end of the class, I'll let you answer that question, okay? But what I will say is they don't get paid a lot and there's not a lot of jobs. Because if you finally get the job at Rhode Island Hospital, you're never leaving. You're not leaving that job? You're just because you're playing Yahtzee all day long and you still have some paperwork and it's fine. Also with games is a lot of emotional control, right? Being happy, being upset, being frustrated, like all of that kind of stuff. So it is a valuable. I don't want to minimize what they do. PT gets a bad rap in hospitals because they say, you just throw a gate belt on and walk somebody. Yeah, but there's so many things I do to get that patient able to safely walk down the hall. Like, again, from the outside perspective, you walk around with a cart and you play rummy all day long, like a rummy and Connect Four. That's pretty good. Anyway, they do a lot of work. So that's the rehab team. Nursing, there's a lot of different types of nursing. Nursing monitors some procedures, medication management, CNAs, personal care, bathing and dressing. Phlebotomists do blood draws, dietitians look at nutrition, housekeeping. I think housekeeping is, I think it's the most important section of any hospital or skilled nursing facility is housekeeping. You got a good housekeeping department, everything else can go okay. If you don't have a good housekeeping, man, it gets bad quick. I don't know if you guys have ever seen like, oh, Nancy and housekeeping's on vacation, and then it's just a disaster for a week. Have you guys experienced that? Oh, is it? Yeah. Yeah. And isn't it something? Have you seen that at your place? Yeah, 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 and it's a huge, the trickle down effect is really something, really something. Then nobody else can do their jobs, you know? So I think housekeeping and then CNAs are the other one. The housekeeping keeps everything clean. CNAs keep the person clean. And that's really important for that person and for everything else too. But yeah, I think those are the two most important departments in hospitals and skilled nursing facilities. If you've got good staff there, you're in a good place. Um, by the way, who makes the least amount of money on this list? Housekeeping and CNAs, you know. So yeah, dietary maybe after that, but anyway, social workers really important, especially in hospitals, access to community resources. This guy is medically stable and can go home, except they don't have access to transportation to get back for their follow-up appointment. They just had, maybe they had a mini stroke. There's no reason to keep them in hospital. There's no reason to um, send them to a rehab, but he needs a neurologist and maybe a dietitian, depending on what the origin of the problem is. And they can't get to the neurologist. We can schedule the appointment for 6 weeks from now, but they're telling me they can't physically get there. Okay, let's find that person a ride. That's what the social worker is. Um, Patient's good to go home, except they told me they haven't paid their electric bill in 3 months, and now they need an oxygen tank that's plugged into the wall. They can't go home because of an electric problem. So how are we gonna, what's the community resource that we can figure that out? So social workers are almost magicians when they figure out solutions to those problems that the rest of the team, like we did all of our job, and then there's this other external barrier that yeah, they're pretty incredible people. Case managers oversee the entire case. Really coordination of care, how are you doing, and all the run around of that. And there's more and more and more. I'm always amazed at the more careers that I learn about that are in the hospital. It's really something. Uh, But communication happens with daily rounds, electronic messaging, case meetings. Those are the big ways. Really big team here. So it's tough for everybody to get together. The daily rounds is where the head physician and all of their residents will go around the unit and talk about each person, what the plan of the day is. So So going to pause here on PT versus OT. We did it a lot. So definition of PT, or what are we trying to do? Optimize movement to enhancing the experience. We said that a bunch. Gross motor we talked about. And improve the person so they can function in their environment. That's my big goal. OT, first of all, what the definition of occupation is, I always, when I was learning about OT, I was thinking occupation makes you immediately think of what? Work, right? So I was always like, oh, what do they do? That's interesting. Well, occupation is anything that's purposeful and meaningful things that people do to occupy their time. Doesn't that sound like human experience? Just a lot more words, right? I mean, what occupies our time? Work, leisure, family roles. Like I don't like doing the dishes, but it's important to me and my family that I do it. To me, that's the human experience, but those things are all occupation as well. Doing the dishes is occupation. Carrying my daughter to bed is an occupation of mine. It's something purposeful and meaningful that occupies my time. Fine motor we talked about, coordination and cognition to some degree. Cognition has to do with more like the sequencing. Like we're not necessarily working on the arithmetic that the speech would, but man, I've had this one patient. We didn't have an OT available, and this guy really needed it, and so I said, okay, well, I'll do the best I can. I was helping him figure out how to get dressed. He had a couple of mini strokes. Um, And he would do the funniest things. He'd put on his shoes before he'd put on his pants. And then he would try to put on his pants and he couldn't figure out why isn't this working here? Like when you work with somebody that has that cognition limitation, you could have a fine conversation with the guy. That don't get me wrong, he was not, I've had some people with, significant cognition issues. This guy had pleasant conversations all the time with him, but man, you get him to try to sequence the steps to get dressed in the morning. How do you shave? You give him three. If you were to give him, hey, we're gonna pretend we're gonna shave, and you put the TV remote control, the razor blade, and then a toothbrush in front of him, he would struggle with which item do I have to pick from. How am I going to shave? And he'd pick up the remote and say, like, why? Like, this isn't. I picked this up, but I know it's not right. What do I do? Almost like when you guys answer a tough question on an exam. Like, I'm going to pick this answer, but I'm not sure why I'm picking it. You guys ever do that? No, you guys just don't know the answer. Anyway, OT helps with a lot of that sequencing work. What OT does a wonderful job with is adapting the environment to the person. Now, that is something a little bit different. I do some of that. You need a handrail here. You need a grab bar in the shower. But man, OTs, anytime I'm stuck, if there's not an OT on the case, sometimes I'll just call up my OTs and say, listen, I'm stuck here. I need to brainstorm with you. And man, they know the thing. So just show you a few items that OTs, I might have shown this to you before, but we got different, these are cool, different utensils. These are pretty cool. So these have a little bend in them and you can change the angle for it. So if someone has trouble getting food to their mouth, let's say their arm doesn't bend all the way, their wrist doesn't bend all the way. It takes a lot of motion to get your hand to your mouth. Well, if it's my patient, I'm going to say, hey, your elbow doesn't bend. I'm going to crank on the elbow until it bends more. OTs say, well, that sounds like it's going to be hard. Why don't we just give them a special spoon and then they can just not have as much, still feed themselves and not have as much motion. So that's pretty cool. We also have different handle sizes. So maybe they can't grip all the way, so they can have just a larger one. And so that's pretty nice. Let's see. These are awesome. These are button hooks. So again, like fine motor. So, putting a button through a hole is a really tough task. Anybody ever have their hand fall asleep and then try to, you wake up in the morning, hands asleep, and try to get dressed? Anybody ever do that? It's like so impossible. So this is a little tool, again, large handle. You slip it through the hole, you grab the button, and then you just pull it right through, and then you don't have to have, you need a grip enough to hold that handle, and then that's it. So that takes away a lot of the fine motor stuff that has to happen. So that's a fun tool. There's a million different, name a task that's difficult, and there's something there. Here's one for zippers too. That's pretty cool. Anyway, so yeah. Elastic shoelaces. Yep. So here's elastic shoelaces. So now you can still wear whatever your favorite sneakers are, except now these are going to they're elastic enough that I can slip my foot in, but then they're going to cinch back up. There's a lot of different versions of that. So well, yeah, slipper socks. That's another thing. Yep, yep, yep. Um, so yeah, but you name the task, you name the task. There's a sock aid. This helps put socks on. So somebody who can't bend down all that far, this is like a little semi-circle. Slide the sock over it, you throw that on the ground, you put your foot in it, and you pull it up, and it just pulls that, like, do it. Out. You can't bend that. So again, me, I would say, well, let's just work on the hip, at least you can bend down. We can say, well, for $14, we don't have that problem anymore. It'll come here, we'll find somewhere to deliver it more than, faster, but these are probably at CVS, to tell you the truth.
Is there a certain level of profit speed? Yeah, how do you know when to start?
Adapting the environment. Yeah, when do we know when to adapt the environment versus just work on their problem? A lot of it has to do with the knowledge of what their condition is to start with. And we always said we talk about clinical reasoning a lot, and clinical reasoning is taking our knowledge about the pathology that they have, their problem, fall risk, heart attack, hip replacement, all of the things that you see day to day, right? Knowing about that and timelines and then also what was my patient's prognosis? So that guy that had the trouble sequencing, putting on and off pants, like getting dressed sequencing, I was there because he had a hip replacement that got infected, and like I was there for that part. I can get this hip better. His cognition, that's a way different problem, right? So taking in their prognosis. So that guy, if it was just a hip problem, I'd say it's a temporary problem. Don't worry about. We'll work on the stairs. Don't put in a ramp. But now with this cognition problem, we might need to put in a ramp. I'm going to work on someone with Parkinson's. I'm going to work on stairs. You should think about in 5-10 years from now, what are you going to do? Right. So it's knowing their pathology, knowing that person's prognosis, knowing their past like level of function, prior level of function that we talked about. And also just having a conversation with the patient. If my patient for $15, there's a lot of my patients that would say, Josh, there's a 20 on the counter, grab it, order it for me, and keep the change. I have plenty of patients. I've also had plenty of patients that I had one guy in particular. You guys ever see the tips on canes? Like they're just little rubber like pieces to it. The tip of his cane was so worn down, it was slick. It was actually using it was a fall risk because it was that worn down. I looked it up and I said, hey, for I think it was $5. It was either $5 or $2.50. Yeah. Hey, at CVS, there's a pack of 2 for $5. So all right, next month I'll put it into my budget and I'll find a way to make that happen. So that's part of the factor. If you don't have $15, I got to work on the hip. You got $15, even if you're going to use this for a couple of weeks, if it helps you save the headache for a few weeks, then I've got plenty of patients say, yeah, no problem. Let's do it right away. So that's unfortunately part of our clinical decision making is what's realistic for this patient. So I don't have the exact answer for you. And every single person with Parkinson's, even though I know what Parkinson's is, and I know it's, I know it very well. I know what's it going to look like in 10 years from now. All of those other things are different. So yeah, not an easy answer for you have a really good question and there's no easy answer for that. But anyway, I talk about that a lot with my patients, just do I need a walker or a cane or something? So, well, if you got an extra $10, 15, $20, you can buy a cane right now and that'll help you a little bit, but I don't think you're going to be a cane user for a long time. So if you don't have the extra $15, don't worry about it because this is in 2 months, you're not going to have a problem. So that's part of the conversation I have. That's with walkers and canes all the time. You know, those four-wheeled walkers with the seats on them, those cost between 80 and $150, depending on what you've got. That's not something I tell my patients, just, hey, if you got it, just go pick one up. Like, cause you're not gonna need it for a long time. Like, we don't need it. Yeah, they've got their own problems with that, yeah. So anyway, OTs do a marvelous job adapting the environment to the person. Uh, and then something else that OT does better than physical therapy is mental health. In fact, at CCRI, we have an OTA program, and they get a certificate in mental health first aid, which is if someone's going through an acute crisis, what are the best next steps to respond with? So it's a pretty interesting thing. Um, I think OTs, if I'm going to be a little bit more, I'm going to paint this with a really broad brush, and hopefully that you guys can understand that there's obviously individual differences. Um, PTs are very rigid in their thinking. The knee doesn't bend. Let's bend the knee. OTs are much more artistic. Why do you need the knee to bend? Why is that important to you? How can we still do that and not have the knee bend? Like it's almost like PTs. A lot of times we get focused on that knee, and we're excited to help the person that's attached to the knee, but we're really looking at the knee. OTs just almost always look at that person and how do we enhance that person. And then sometimes it feels like they forget that there's a knee attached to that person that we also need to address. So it's just, you know, we're basically tackling the same problem. And the outcome is good outcomes for the patient, getting back to what they want. It's just how we get there is a lot different. Very rigid thinking versus almost artistic thinking in the OT world. Um, so really great people. Definitely people I appreciate having on my team. I love working with our OTA department because they're just great people, and they also just they approach the whole thought process is the same reason why they're in OT. So oftentimes I'm good friends with the OT director, and there are oftentimes we both share back and forth. Hey, I met this person. They'd make a great OT. Can you reach out to them? And then she'll do the same thing. Hey, I met this great person. Uh, they'd make a better PT than OT. Do you want to reach out to them? So, because sometimes there's a core, like you can kind of see it from a mile away. But anyway, again, not always, but I have to update this slide. So CCRI, we talked about our admissions program, or the admissions to the program. OTA just changed theirs, so all of this is needs to be updated. They still have two application periods, February and spring, although now it's a 24-month program instead of an 18. The way that they had their when I created this, they used to have a lot of the prereqs that you guys are taking now. And you guys have the three major prereqs that you have. And then you also have to take anatomy too. You also have to take before you graduate. What are some of the other ones? Math, English. So you don't have to have math or English to get into the program, but you have to take it before you graduate. OTs basically had all of those as prereqs, so that once you got into the program, you only had OTA coursework to do. So that's why it's basically the same now. So anyway, but they still have a ranking system based on points. They have two application periods instead of one. There is that additional students graduate with their certificate of mental health first aid. And I will say historically, it's not as competitive to get into the OTA program as a PT at CCRI. I forget. I think they have 15 students in their last admissions, so they weren't even. They have 24 seats, but they weren't full. They haven't been full for a little while So I think it's a great program. They do a great job. And we've been talking about, there's so many similarities between PTA and OTA. There's some good differences too, but there's a lot of similarities where, if you're interested in it, you can please talk to me and I'll get you right over to the director of the program. She's a wonderful person. So. I don't have that off the top of my head. We can try to find it before we leave class. Actually, I'll just text the director of the program. He usually gets back to me pretty quick, so we'll see what she gets back to. So anyway, I think we do a great job with our OTA program. So going back to our skilled nursing facilities, depending on the size of the facility, we have some SNFs that are very, very small and some that are very, very large. So it is a smaller team than the hospital. The major difference between hospitals and skilled nursing facilities is hospitals are required to have physicians round the clock. If you have a hospital, you have physicians in the building at all times. Skilled nursing facilities, physicians are not part of the team. Physicians can come in and out. They can check on their patients. They can, definitely happens, but they're not employed by that nursing. But there's definitely nursing, PT, OT, speech, CNA, social workers, housekeeping, and on and on and on. Maybe recreational. It depends on the size of the skilled nursing facilities. What other types of professions are there? I know of one place, they have a dialysis center in it. So they have phlebotomists there, which is cool. Yeah. Yeah, it's pretty. When I saw it and I go, well, of course you should have that, because there's plenty of patients that are on dialysis that need nursing home. Like, yeah, it makes a lot of sense. But you have to be big enough to do that. So anyway, so communications happens with rounds, but also case conferences, electronic messages, and also informal conversation, which happens a lot. So informal conversation means, it happens every now and again for us as we're coming to class. Like if we take the elevator, I say, what's going on? How are you? Tell me about your other classes. Before class, we're all here early enough. Like that's kind of informal communication. That kind of stuff can happen in a nursing home because it's a smaller place. It's 3 floors instead of, anybody have any idea how many floors Rhode Island Hospital is? Over 15? Yeah, a lot. I think when I worked at Newport Hospital, there's 6 floors, 7 floors, something like that. And that's a small hospital. As far as hospital standards go, it's small. But yeah, nursing homes, if you got a 3-floor nursing home, that's a gigantic nursing home. How many do you have? 1 floor, yeah. So yeah, how many break rooms are there? Like staff break rooms.
3, maybe more.
3, yeah, 3 or 4. Yeah. Hospitals, there's a physician break room, there's a nursing break room, like you're almost purposely kept apart and on way different floors and all that. So informal conversations are really, really important and can enhance care. The director of the OTA program texted me back. I asked her, is there anything important you want me to talk about? She said, yeah, how OTA is just like PTA, but way better. That's good. And it looks like average salary is competitive to PTA. Roughly same numbers. I don't know of any OTA versus and PTA combos. I would wonder, there's got to be an aspect of that field that you really like to make you do that. Um, like I know in the OT world, they do a lot more fabrication of splinting. But because there's so much overlap, I don't really see why you would be an OTA and move into PTA or a PTA move into OTA, like it, because it's so much similar job. Um, I have a really good friend who started as a PTA and then he got his master's in OT. Um, so I know of some people that will do that, but that's now a different job because you're moving into the doing the evaluations instead of executing the clinic care. So, yeah, I don't know of anybody that would do both. I don't see a reason why you would do both. Same job, similar pay. So, I should say similar job. Anyway, other settings, home care. Again, smaller team than skilled nursing facility. Some home care agencies have social workers, others do not. The minimal members of the team, nursing, CNAs, PTOTs, speech, and case managers. Um, Communication happens directly. I have to call the OT and say, I have a question about this patient. Um, Case conferences we have every 2 weeks. Informal meetings are less common because we're not all on one building, right? Skilled nurse facility, even hospitals, at least we're all in the same building. We might not be in the same wing or on the same floor, but at least our cars in the same park. Um, it's so funny. We're in the home care world when we run into other clinicians, right? I go in at 10 a.m. and the nurse comes in at 10:45. Like it's so funny when we see each other. It's like, oh my God, look at you. Like it's just like this reunion because we never see each other. We see each other at a holiday party once a year. And then a few times a year, we'll have in-person trainings and education. But yeah, other than that, we don't see each other. Um, so the informal meetings are less common than that because we're not all at the same place. And outpatient is the smallest and most specific teams, PTs, PTAs, techs. There's still care coordinators, like front office type people, billing department. In your place, do you have a separate billing person versus front? I always call it front office, back office. No, I was still asking Rook. Yeah.
Yeah, yeah. Yeah, I think so. No, yeah, yeah, we have a whole building department. You know, but our patient care coordinator who works the front desk.
Yeah.
Also, she does.
Right.
She does some of the building stuff lightly.
Yeah. Yep. Yeah, so it depends on the business, but there's also, I was trying to figure this out the other day. I was actually just talking with somebody at High Bar. You know how many clinics High Bar has right now?
Like 20.
20 is what my estimate was, but I know they're adding more and more all the time. So that team is a little bit different in a 20 clinic business versus just one clinic business, right? So sometimes I know some solo practitioners that it's just the PT. They do the scheduling, they do the billing, they wear every single hat. Sometimes there's other places that there are OTs and OTAs that work in the same building. Sometimes there's also personal trainers, nutritionists. I have a friend who owns his own practice. Um, he has two PTs that work under him, as well as personal trainers, nutritionists. And you know, he's really looking at more of the personal training and wellness type model versus just strict call me when you get hurt. So you should be here all the time. But that depends on the practice. But communication occurs directly, informally, and mostly for all of these places with our documentation. Everything should be documented. That's really important. And documented, when I say documented formally in the patient's chart we talked about this. This is the rule. This is what we're gonna do. If we have time, maybe I'll show you a nightmare story about that. Schools, like we talked about, the unique aspect, non-healthcare workers are involved in the team, teachers' aides, principals, families, bus drivers, bus monitors. You know, there's a lot of people that are in the schools that are not healthcare members at all. So my wife works in the schools, and she's got this one kid who has a pacemaker, and every single person on this list was petrified by that kid. Oh my God, can that child be running? Oh my God, what's going to happen if they get bumped into the hallways? Oh my God, this person can't play dodgeball. Nope, all of that's fine. They're fine. They've got a pacemaker. And actually, pacemakers nowadays are so incredible that if something goes wrong with the pacemaker, it's going to tell us on our phone. It's going to the pacemaker will text our phone. Call your cardiologist. Actually, the cardiologist just called us because the pacemaker called the cardiologist for us. Like it's really incredible. So it's up to us and as the healthcare workers to teach all of these people that know when there's a fire alarm, they can walk outside quickly and not, we don't have to worry about their heart exploding. Let's not worry about that. So anyway, the school nurses, that's part of the team too, really crucial part of the team too. Anyway, communication occurs directly, electronically in case meetings. The case meetings are, they happen less frequently in schools. They're formal, it's called IEP meetings, individual education plan meetings. They can't happen all the time, but I forget the minimum. I think it happens either once or twice a year. Don't tell my wife I don't know because she talks about it all the time. Oh, I had this IEP meeting, and I say, oh, I pretend like I'm paying attention. Like, you guys ever do? Do you ever do that, Cam? Do you ever do that at Gabby? Pretend you're doing that to me right now, pretending to pay attention. Did you guys see that? Fucking solitaire, and he finally looks up and goes, "Oh yeah, Josh." How that feels? I gotta start paying attention. All right, so your question about recreational therapists, I said you're gonna answer your own question in a minute. So we have a homework this week. This is the team models brochure. I do not spend too much time making it pretty. I want it effective. You don't have to go crazy. This isn't a graphic design class. But your job is either flyer, brochure style, tell me about a profession other than physical therapy. So if you wanted to pick recreational therapist, great. If they are going to do a flyer style, it's got to be front and back. Brochure style, obviously, you fold into the 6 panels. But right as if you're going to drop it off, what's the closest high school? Tollgate High School just down the road. We're going to walk into Tollgate and we're going to hand them a stack of flyers. Say, hey, if your students want to learn about this profession, here you go. So what we want is the level of education required, typical work environments, what licensing and certification requirements are, salary range, and just a general overview, day in the life of whatever your profession is. So if you want to pick, if I'm going to do PTA, level education, associates, typical work environment, hospitals, schools, outpatient, number one, most common practice, licensing certification, graduate from an approved school, pass a licensure exam, pass a background check. Salary range for new grads between high 40s to low 70. I just had a student just told me his number. He's getting paid over $7,000 for his first job. That's pretty good. More than what I'm making teaching you. It's threw me for a loop there. And then general data view. What am I going to write? I'm going to write enhance movement to optimize the human experience and optimize movement to enhance the human experience. Work with patients of all ages to improve mobility. Yeah, what any other job description you might have. So make it look nice without exhausting your time. I'm not, there's a piece of the grade, but I do not want you guys saying, it took 4 hours doing this. And get it done with good content and make it not look ugly and you'll be fine. Okay. Any references, use just web links, just include the hyperlink to it. Professional organization sites like the APTA is a great one to use. State licensing, employment, Indeed's always got plenty of job outlook type things. So, there's it doesn't have to be well researched. Like just any website will be fine. I if you just throw the website link, then I'm good. Yeah, yeah. Um, and then upload to discussion board. So in the discussion board, I'll show it to you. I'll show you where I found it. I put in all of these links. I haven't tested them recently, but here's all the links of the CCRI programs. So if you want it to be your most time efficient, you just click on the link. There's a bunch of resources for you right here at CCRI about what other programs we offer. Here's the grading rubric at the bottom. So, feel free to make sure you glance at your material and make sure you're going to get a grade you'll be happy with. And what I want you to do is upload it in the discussion board. So here's the team models homework. You can click on it. All you're going to do is create a thread and then you upload whatever you have. And then exactly that Word document is right there. So if you want us to look at those links or anything, yeah. Throw it right on the flyer. Right on the flyer, yeah. Somewhere. Yeah. Okay. Yeah, I'd like it done by next class. Yeah. If you get in a real jam, let me know, but I'd like it done by next class. Yeah. That's why I say don't spend too much time making it look perfect. Make it look nice without taking up too much of your time. So all right. Any other questions on the stuff that we covered? Oh, we got to go over the objectives. Sorry. Make sure we tackle that. Make sure we learned everything we're supposed to. All right, members of the rehab team, rehab specifically, or three major ones. PT and PTA. Yep. Yep. Patient's always a member of the team. Yeah, I didn't put that. I wasn't thinking of this when I created this objective, but you're right. So rehab team specifically would be PT, physical therapy team, PT and PTA. What other professions? OT and OTA. Then one other one is considered the rehab triad. Speech is the, yeah, those three are considered the rehab teams, although the recreational therapists would quietly in the corner and in between rolls of the dice say, hey, what about us? You're right. But those three are when we talk about rehab team, it's those three professions. So the role of each member of the team, each member of each profession in the team. So, I think the slide to look at that is the hospital slide, members of the hospital, physicians, what is their job? Nursing, what is their job? CNAs, what is their job? Housekeeping, what is their job? So make sure we look at that. Characteristics of an effective team, advantages and disadvantages. Oh, sorry, just the advantages of using a team approach. What's the main advantage? Two that I can think of. Better outcomes is the number one thing. Faster and better outcomes. A person after a stroke is going to get better, faster, and to a higher level when we work as a team versus if we just work in, individual aspects. Even if we're all perfect at our individual jobs, when we can collaborate and work as a team, that's where we're really going to improve upon that patient. Yeah. And then the various clinical settings, identify teams in each setting. So hospitals, it's everyone. Skilled nursing facilities, we take away one profession, which physicians are the one we take away. We might take away more depending on the size hospital, like phlebotomists probably don't work in nursing homes, but definitely physicians will be taken out. Home care, what members of the team? Nursing, yeah, skilled nursing as SN, yeah. So nursing, CNAs, PT, OT, and speech, yeah, the rehab team, yeah, and then case managers important there. And then outpatient would be the other setting, so, all right, any other questions on the objectives? Perfect. And this here. Good luck studying.